Hi, this is AJ Heitman, the editor-in-chief of GEMS, and I'm pleased to bring you to the EMS Today show. This is an epic episode because what we're talking about today is a concept that's not new. It's a proven concept on proning of patients that are in acute respiratory distress syndrome, and it's now been found that it works extremely well on patients who are the happy hypoxic and that we're seeing in the field from the coronavirus. With us today is a great panel. We have David Farsi, who's the chairman, Department of Emergency Medicine, Director of Emergency Medical Care at Mount Sinai Medical Center and Hildebrand Emergency Center in Miami Beach, Florida. He has a wealth of experience and he's the president of the American Academy of Emergency Medicine. We also have Ken Shepke, the state EMS medical director from Florida and the chief medical officer in the very progressive Palm Beach County Fire Rescue System. We have E. Reed Smith, who's the Operations Medical Director for Arlington County Fire and Police Department, Associate Professor of Medicine at the George Washington University, and a system that's already using what we'll call proning, or modified proning is what in my vernacular. And then we have David Slattery, who is the Professor and Director of Research, Department of Emergency Medicine, UNLV School of Medicine, and the EMS Medical Director for the very busy city of Las Vegas Fire and Rescue that will be implementing proning in the future. So I'm going to turn it over to you, Dr. Farsi, to explain to us how this has been helpful in ARDS and what you found in your research with these patients.
Let me, number one, I just want to say thank you very much for the invitation. And I started my career in EMS, and EMS is a true love for me. And let me, and so I want to thank all our pre-hospital family for what they do, and all our medical directors for what you do. People say we're the hero, but you guys are really the heroes for doing what you do, and please continue staying safe. Let me start by saying this is probably one of the most important slides. There is no such thing as an emergency during a pandemic. You must wear the proper equipment, your mask and your gloves and your PPE. Running into a fire without gear and dying, you just contribute to the problem. So, this is one of my favorite movies, The Matrix, and it's like when they're trying to bend the spoon and says, "Hey, is there really a spoon?" And it's like there is no spoon, right? This disease has challenged every concept that we actually know. This disease is not a disease that we know. It's a novel virus that requires novel therapy. We use a lot of expertise saying this is not safe, this is not safe. And this led to intubating patient early because we felt they were going to crash and we needed a control environment. Well, let me tell you, I'm actually doing research and collecting our old data right now, and we're doing a prospective trial. In 6 weeks, we had 171 patients that either died or intubated in the first 4 weeks. And until one patient looked at me and said, "What the hell are you doing?" Like, I want to go AMA. And his pulse ox was 71 or 69. And I'm saying, what the hell? And I'm having a debate with this guy, arguing, saying, how can I let him go AMA? He's hypoxic, right? Any emergency physician will tell you hypoxic, he's probably altered. But I'm having an argument with this guy, and this guy is making more sense than I was. And I was saying, this is unbelievable. And the guy, when I put him on oxygen, he went up to 88 on nasal cannula. And every time I watched him sit up, go down, then his O2 sat would go up. And every time he would talk to us, his O2 sat would go up. And that's started saying something is wrong. This is not a disease that we've seen before. We've done, I've done multiple education podcasts with the Rebel EM, with AEM, where you can find it online. But basically, this is what we're facing with, right? We're facing with data out of China, Seattle, New York, UK, with a mortality rate of 67 all the way up to 88% mortality on ventilator. Now, yes, everybody can quote me the Harvard study that just came out where they have only a 33%, but I would argue that they intubated people way too early, and it should not. and I'm going to use the word, and actually, it's not really me coining the permissive hypoxemia. I would love to give it to Paul Pepe. Dr. Pepe is probably the first one who said this is permissive hypoxemia. But EMS are generally the first one to come up with novel ideas and new ideas. And EMS was the first one to say, man, those guys are happy hypoxemics. And I'm sorry for my accent, happy, H-A-P-P-Y. And if you look on this is a girl in New York City who's sitting, and if you cannot see, she's sitting at 54%, respiratory rate in the 30, and she's down and texting. Now, every single one of us before this pandemic would rush to intubator, respiratory rate of 30, 40, O2 sat in the 50s, and we would think, oh, she's going to tire out. She's going to crash and burn. But we don't see this happen. Now, this is another patient where patient initially came in, O2 sat of 61. We put him on the side and went to 88 and then 95. Where do we get that data? Proning has been used in ARDS patients who are intubated as a last resort. What it allows to do is your lung is made of balloons. And so on your gravity state, so if I'm sitting up, the air is up here and the blood is down below. If I lay flat, the blood goes to my back, the air goes to my chest, and the blood collection causes what's called atelectasis, collapsing of lung units. So when we move the patient and we prone them and move by using motion to go on the side and then face down and then on the side again and then face up, we're changing what's called a VQ perfusion, ventilation perfusion. And basically it's just move the blood and to allow the air to reinflate those collapsed alveoli. And we do this, and studies have shown in ARDS patients, 12 hours a day, it significantly decreased some mortality. Now, there's only been 2 trials in the literature of awake proning, 4 patients out of Sweden and 16 patients out of another country that I don't remember in front of me, where they showed that patient, if they followed the instruction, then they benefited from awake proning, even with severe respiratory distress. Now, the patient must be alert. The patient must be able to follow command. The patient must be explained that that nasal cannula or that high flow oxygen that you're putting is their lifeline, that they must hold it in place, because if they don't, with movement and it comes off, it could be catastrophic, because the numbers drop, everybody rush, and they're like, oh my God, we need to intubate that patient. Just put it back. Now, there's been some concern about using high flow, and this paper just got published in Chest, and it shows that if you're using a face mask with high flow oxygen, you can see that the propagation of the particle is almost completely stopped. The velocity of it is completely stopped. And so the questioning of the safety is almost none. I can tell you in our institute and my shop, every patient that we prone, that we use on high flow with a face mask, we have a 0 case of contamination by any of our staff. So that's kudos to our staff. And by the way, every patient on those slides have written permission for us to use. And this is an example of a patient who is slightly morbid obese and is unable to prone. And if you notice that we use a pillow on when he prones, meaning face down, and that patient, we notice there's really no major improvements when morbid obese prone. So our protocol has been changed to, they go to the right for 40 minutes, supine, go to the left, and then they sit in the chair for 2 hours instead of proning, just again to change that VQ mismatch. There's some, bin table of everything that people are talking about proning. In our data, and again, I'm not gonna talk much about my data because it's hearsay for now. It's observational and it hasn't undergone peer review, and now it's going through the peer review process. But I can tell you that we significantly decreased the number of intubations. We decreased the number of length of stay in hospital and ICU. Yes, we had some patients who had to be intubated after 2 days and 3 days. Yes, we had some expiration, but the majority of the patients that are happy hypoxic, able to follow command, able to hypoxic, and there's no major changes, and they're comfortable, then they did fairly well. Again, I want to say, this is observation for this time. We're seeing more and more data saying that it probably will be true, but I strongly urge that everybody at least try. You'll see the patient, you can walk to him, he'll talk to you. They kind of walk like they're on Mount Everest, and this is where early on in the disease, everybody confused it, saying it was high altitude pulmonary edema, which is nothing to do with high altitude, but they do have similar feature where they walk with fatigue, they step by step and word by word, and you put the oxygen and the mask, and next thing you know, the guys are like running and talking sentences.
So, Doctor,
again, thank you so much.
Could you explain the dots on the right side on your diagram? Is that what does the dot represent?
This
in each position, you obviously are looking at what happens when they're in each position.
Yeah. So when you're looking at the dot on the lungs, that's where the air is, right? And the blood is at the bottom. So if you're left side down, then the air will be up in the upper segment. If you're left side down, put left posterior segment down. It just indicates where the blood is located and where the air is going to be. It's just, this is taken from Google, so it's just to show some of the different position where air versus blood will be.
So with COVID, it's really a blood-related problem as well. We're trying to get that blood up from away from the spine, and we're trying to get the air moved around a little bit better. Am I correct?
I wish it was that simple. I call it the devil. I call it the devil disease. Dr. Shepsky has put in probably one of the most amazing group of experts that I've ever been part of, and he can tell you himself that this disease has challenged every single one of us. It is not just the blood; it's the cytokine inflammatory cascade, the microembolism. It's way too long for me to even go into this. Dr. Shepsky, I'm sure, will be more than happy to explain some of it.
Yeah, we're going to segue over to Dr. Shepsky, because in his system in Palm Beach County, you've instituted at least a portion of proning. So Dr. Shepsky, why don't you take it over?
Sure.
Ken, you're cut off.
Can't hear you. You're on mute, Dr. Shepsky. We got you. We got you now. Are you there? Ken, it shows that your microphone is off.
Yeah, I had a problem with the Bluetooth. It signed off for a second.
We got you.
Sorry about that. So I was just complimenting Dr. Farsi on the excellent work that he's been doing. He's been a real leader in this field. Now it says I'm muted by a host. You guys still hear me okay?
Yeah.
All right, great. So we started doing this. I looked at the data on this, and these happy hypoxemic patients, meaning they're hypoxemic but they're not hypoxic, meaning their O2 sats are low, but their tissues are not producing lactic acidosis, meaning somehow there's enough offloading of oxygen at the cellular level that you're not actually going into anaerobic metabolism. It's very odd with this particular disease. It's been very humbling. It's challenged a lot of the things that we thought we knew about medicine. And just a simple technique of taking these folks who are, and let's be clear on this, awake, alert, can follow commands, and can keep their oxygen on, and having them change their position, that drastically changes their O2 sat. And this is critical even in the pre-hospital field. And a lot of times I hear things that, well, our transport time's only X minutes, whatever X minutes happens to be for you. And that's really not a reason to withhold this thing, because what we were seeing, just a simple maneuver of taking these folks, O2 sats in the 80s, but they're awake, on oxygen O2 sats in the 80s, have them roll over onto their side, left side, right side, or even onto their belly if they can tolerate that. And within 5-10 minutes, O2 sats up in the lower 90s. And now you've taken somebody that you're really thinking about intubating, and your O2 sat is actually in a much, much better shape, and you've really improved the aeration of the lungs and delivery of oxygen to their body. So pretty simple technique, takes seconds to do, is absolutely free, and completely reversible. What more could you want in medicine?
Yeah, and what have your results been? What do you see anecdotally or statistically?
Yeah, as well, I've been up at the Emergency Operations Center in Tallahassee, so I haven't been with my friends in Palm Beach County who I work closely with, so I haven't been able to get the results as closely as I'd like. But so all I can give you is the anecdotal reports rather than give you the actual statistics that I like to do when I do these things. And we're seeing what everybody else around the country is that when you take these patients and roll them onto their side, you see dramatic improvements in their O2 sats within minutes. So it's really well tolerated, very simple to do. Doesn't take a whole lot of training. Here's your training. If you have a patient with low O2 sat but they're awake and their mentation does not seem to match their O2, they meet the definition of what we're calling happy hypoxemic, where even though their sat's low, they seem to be not suffering from it. Tell those people to roll onto their side or onto their belly and see if their O2 sat gets better. If it does, keep doing it. If it doesn't, have them roll back.
So like so many things that we've done in the pre-hospital where the hospital didn't understand why we were doing it, like mechanical CPR, et cetera, how do you convince the hospitals?
Well, we've actually been pretty fortunate. We have a network of docs in South Florida where we've been doing this, and many of them are in our larger hospitals. So they've been on our webinars that we've been holding a couple times a week. So we've been discussing this, and they're aware of what we're doing. So yes, you're right. Normally we do stuff in the field and we get all sorts of raised eyebrows when we walk in. But with this particular disease, we've been doing a fairly good job of keeping everybody informed in the emergency department so that they had a better idea of what was going on when we did it.
Okay, and let's go over to Reed Smith from Arlington Fire. You've been doing it. Tell us what your experience has been.
Yeah, my experience is very similar to Ken's. You know, in Arlington, we started this a couple of weeks ago. You know, with the, you know, kind of along the same thought process that everyone has talked about. And we've had a great experience. You know, we haven't had that many patients because, you know, we do require the patient to be awake, alert. They can't be in, so tachypnic, you know, so above 30, we're not going to do it. They can't be obese. So, you know, we've had, I think we had a case, a couple that really, I was working in the ER. We had a great case, 34-year-old, who was statting in probably the 60s, I think in the mid 60s. When the guys came in, they put nasal cannula on him, put a mask on him. Sat came up to the mid 70s, and they put him on the stretcher, bringing him to the hospital, and he wanted to lay on his side. And so they allowed him to lay on his side, and they actually told him to, why don't you try to roll on your belly? He rolled over onto his belly. His sat, when he rolled into the ER on 6 liters of nasal cannula, his sat was up in the mid 90s. And we were able to keep him from being intubated. And, and he has done well in the hospital and was able to, with wake proning in the hospital, he was able to be treated and discharged without ever having to be intubated. We had a 93-year-old that we were able to, who was a very functional 93-year-old at home, same kind of similar situation, who again, was not in terrible respiratory distress, but was hypoxic in the 70s. And we were able to get her back up on her side, and on her belly during the transport. We were able to get her up into the low 90s. Again, now she's still in the hospital now. But our goal in EMS, our goal is to keep these patients from being intubated. And if we put them on their side or their belly during transport as safely as we can, and keep them from being intubated in the field, if we can buy them time to stay off that ventilator, that helps quite a lot. And I think we've had great success. The hospital has been pleased with it. Our providers find it easy to do, with the right parameters. Is we're not forcing somebody over onto their belly who can't, and we're gonna just allow them with a little positioning and oxygen to keep them off that.
So you said a key thing there, Reed, and that is that that the hospitals are pleased with it. So the hospitals carry it through. And do you find that those patients, the mortality is less?
Oh, I mean, I think it's anecdotal, similar to, what's been said. So, I don't have enough to say that it's anything other than anecdote, but I know that when you look at the overall COVID numbers, the people who are committed to a ventilator, I think it's roughly in the 80% range of mortality. So when that's almost a one-way ticket. So anything that we can do to buy time off a ventilator or bridge you so you don't go to a ventilator is good. And so I think that by doing this, by keeping people off ventilators, we're improving the mortality of this illness. So, and certainly it's a lot easier. I think there's a big risk. The aerosolization procedures in the back of an ambulance are very, very high risk. Low cubic volume of air. Are in a closed space and tight. And these are difficult intubations. Anything we can do to prevent the intubation in the field and bridge that patient to the hospital, and then hopefully bridge them so they don't have to be intubated even in the hospital, is a good thing to do.
Well, one of my close colleagues, she's a critical care PA at Scripps La Jolla, and she had me on the phone and she said, AJ, it's amazing. We have proning beds. And she said, when we put somebody in that proning bed, we're in the 80 and 90 percentile that they're walking out of the hospital. She said, it's amazing. And that's when I heard the discussion at Eagles about this. I thought, wait a minute, we got to educate our friends about that. And, Ken and Dave, it's up to you to make sure that all the Eagles watch this little episode so they begin to understand it. Because what I heard the other day was, nah, we don't do it. And then Ken was like, why? And the other day, Craig Manifold said, guys, this is a no-brainer. We're talking about something that, if the patient has a fracture or a flail chest, we put them into position of comfort. The same thing here. When I was a young medic, if somebody was in CHF, we were told to sit them up and take their legs and dangle them off the side of the stretcher. Tell me how safe that was, but that's what we were told. Dave, you're a man of science, and your system is going to go to this, and you've done a training video that you might be able to share with us, but share your thoughts on it.
Yeah, thanks, AJ, first of all, for inviting me, and great discussion about this. This is one of those things that obviously all of us in the emergency department and the ICUs are using, and it seems like a natural translation to EMS. And like I shared with everyone just before when we were chatting, that my eye-opening moment was for Journal Club, for our emergency medicine residency Journal Club this last week. We had Dr. Nick Caputo from Lincoln, who recently published in Academic Emergency Medicine their experience with 50 patients in proning, and the story that led to that discovery, or at least that realization of how easy this is I think really, really telling. And he kept getting resuscitations called out into triage, patients being brought in that are hypoxic, right? That permissive hypoxemia or that happy hypoxic patient. And after a while, simply just asked the patient, hey, can you turn on your side, turn on your stomach? And they did, and SATs came up immediately. In their data, within 5 minutes, the SATs came up. And so that was the first kind of, at least for me, eye-opening that, hey, this happens fast, and we don't need any fancy tables or proning beds, that we can be doing this in the field. So I agree with Reed and Ken and Dave. This is something that very easy to do in the right patient. And again, anything we can do to bridge that patient to the ED is helpful. And we know that about 24% of the patients in the Caputo study ended up getting intubated, but still there was a bridge of about 30 minutes for those that got intubated really early, which is what we need in EMS. And so we don't want to be doing these intubations in the field if we don't need to be. So yeah, we're about ready to roll this out, and I think it's going to be pretty straightforward. And it sounds like, since most of this is anecdote, that we're going to put a call out for maybe a national study that we can work on. So maybe this team can work on putting that together.
I think that will be dramatic. I think everybody's going to save their data and be able to show maybe some outcome studies. But this is really like the work of Keith Lurie and Brett Myers and Paul Pepe with elevation of the head and pressure changes, and in cardiac arrest. It's all of a sudden, well, wait a minute, when the patient lays on their side, they get better when they lay on their belly. If they can lay on their belly on the way to the hospital and hug a pillow, let them lay on the belly and hug a pillow. If they're not comfortable, put them on their side. But I think the information that we shared here is really life-saving, is really, you know, putting out to the group that, you know, forcing somebody, it's like forcing a CHF patient to lay on their back. You killed them, you drowned them. And with an ARDS or with a patient in COVID, if you lay them on their back and all that stuff accumulates, it just, as I understand the science, it just begins to multiply and multiply. It's like somebody making taffy, and then pretty soon you can't get that out. So, you know, I want to thank everybody. This was a great exchange of information. This will be up rather rapidly, which is what I like about it, along with the studies. And then, Dave, as soon as you can get me your training video, email it to me, and we'll put that in there too. So, you know, early is better, because if they can save some lives over the weekend because of what they hear here, I think we're going to do some great work. Dr. Farsi, good luck with your studies. Thank you for being involved. Ken, Dr. Smith, you know, you guys know that I love working with all you guys, and appreciate y'all being on.
Thanks, AJ.
Thanks, AJ.
Okay.
Bye, everyone.
AJ.
Stay safe, everybody.